All right, let's walk through one of the most common and most critical respiratory emergencies you'll ever face. Think of this as your practical field guide for managing an acute asthma exacerbation, all the way from the initial assessment to a safe discharge. So, let's set the scene. Your patient can't breathe. They're panicked, they're gasping, and they are looking right at you for help. You have literally minutes to make the right moves. So, what's the plan? Let's break it down step by step. First things first, before we can treat it, we have to really understand it. What exactly is happening inside the lungs during an asthma attack? Getting this part right is the foundation for every decision that follows. Okay, so the clinical term we use is an asthma exacerbation. And at its core, it's an acute episode where all those classic symptoms flare up because of a sharp decrease in expiratory airflow. And that's the key right there. The main problem isn't so much getting air in, it's being unable to get air out. So what's actually causing that airflow problem? Well, it's really a triple threat. I want you to think of the airways like tiny little straws. First, you get inflammation, which makes the walls of the straws swell up. Second, you have bronchoconstriction, which is when the muscles around those straws squeeze them tight. And third, you get mucus hypersecretion, which basically clogs them up with thick gunk. So they're swollen, squeezed, and clogged. That's the whole pathophysiology in a nutshell.
And what kicks this whole process off? Well, the triggers are usually things we see every single day. Viral infections are a huge one, right alongside classic allergens like pollen or pet dander. But don't forget, it can also be things like air pollutants, certain medications like NSAIDs, or even strong emotional stress. Okay, let's shift gears and head to the emergency room. A patient has just been brought in, and they're in clear respiratory distress. The clock is officially ticking. So what are our immediate first steps? It all starts with that initial assessment.
Now listen, before you even think about asthma-specific treatments, you have got to rule out immediate life threats. It's always back to the absolute basics: airway, breathing, circulation. Why? Because an albuterol treatment is completely useless if the patient is in the middle of a full respiratory arrest. So, is this patient about to collapse? That is always question number one. And these are the red flags. The signs that tell you this isn't just a severe attack, it's a potentially life-threatening one. Drowsiness or confusion? That means the brain isn't getting enough oxygen. And a silent chest? That is absolutely terrifying. It means so little air is moving that you can't even hear a wheeze anymore. When you see these signs, your brain has to immediately jump to preparing for potential intubation. You have to be ready to go. So, we've assessed the patient just by looking at them. Now we need some objective data. We need numbers. That's where peak expiratory flow, or PF, comes in. It's a really simple measurement of how fast a patient can blow air out. And in this setting, it's as important as a vital sign. It gives us a hard number to quantify exactly how bad that airflow limitation really is.
And this table here is how we put all those pieces together. This is the genus severity classification. Just look at the columns as we move from left to right, from mild/moderate to severe to life-threatening. Notice how the clinical picture changes. The patient goes from speaking in phrases to just being able to get out single words, to being too exhausted to speak at all. And this table beautifully links those things you can see and hear with objective data points, like a respiratory rate over 30, an O2 sat below 90%, or that PEF number we just talked about, at or below 50%. This is how we officially grade just how bad the attack is.
Okay, so let's go back to our patient. We get them to do the peak expiratory flow test, and the number comes back at 45% of their predicted personal best. So we take that number, 45%, and we map it right back to our JANA table. And where does it fall? Right there, squarely in the severe category. And just like that, we've gone from a general suspicion to a clear diagnosis with a defined severity. We now know exactly what we are up against. Okay, we've assessed the patients, and we've classified the attack as severe. Now it's time to intervene. How do we stabilize them? Let's walk through the core treatments that you need to know. That first hour is absolutely critical. Our response follows a pretty clear 4-step algorithm. Step 1, oxygen. We need to correct that hypoxia and get their oxygen saturation above 93%. Step 2, ASABA, like albuterol. This is our frontline bronchodilator to open up those airways fast. Step 3, ipratropium. This is another bronchodilator that works on a different pathway, giving us a really nice 1-2 punch in severe cases. And finally, step 4, systemic corticosteroids. We give these to start tackling the root cause of the whole problem, that underlying inflammation. And this slide gives us a look at the typical dosing. Now, the key takeaway here isn't just the dose, it's the frequency of the bronchodilators. We're giving albuterol and ipratropium every 20 minutes for that first hour. We are hitting this hard and fast because we have to break that cycle of bronchospasm. And notice, for severe cases like our patient, we're also adding IV magnesium sulfate, which acts as another smooth muscle relaxant to help force those airways open. But what if the patient isn't responding? What if they're just not getting better? For these tough, refractory cases, we have a couple more tools in our belt. We already mentioned IV magnesium sulfate, which is really key here and has been shown to reduce hospital admissions. And in the most dire situations, we can use IV beta agonists like epinephrine, especially if we suspect there's also some anaphylaxis going on. All right, we've administered the first round of treatments. The patient is hopefully a bit more stable. Now comes the next critical decision point. Do they need to be admitted to the hospital for more care, or are they safe to go home? This whole decision really hinges on how well they responded to that first hour of aggressive treatment. This slide breaks it down perfectly. Let's look at the left column. We're definitely thinking admission if they came in with a PF below 25%, or if after a whole hour of treatment, they still can't get their PF above 40%. But now look at the right. We can start thinking about discharge if they've shown significant improvement, if their PF is getting up into that 60 to 80% range and their symptoms are gone. It's a clinical judgment call, for sure, but these objective numbers are what guide us. Okay, so let's say our patient responded beautifully and is now ready for discharge. Our work is not over. In fact, you could argue that some of the most important work is just about to begin. Let's dig into the discharge plan to make sure this doesn't happen all over again. This quote just hits the nail on the head. A solid discharge plan is just as critical as the emergency treatment itself. This is our chance. This is our moment to turn a scary crisis into a real opportunity for the patient to gain much better long-term control over their asthma. So what does a really good plan look like? Well, it has 4 critical parts. First, medications. They need to continue the oral steroids to stamp out all that leftover inflammation, and we have to start or step up their daily inhaled corticosteroid to prevent future inflammation. Second, a written action plan so they feel empowered to act early next time. Third, trigger avoidance counseling. And fourth, and this is crucial, a scheduled follow-up appointment to make sure they're on the right track. And this right here points to one of the most common, yet most overlooked reasons for poor asthma control, just bad inhaler technique. Handing someone a prescription is not enough. We have to physically watch them use their inhaler and teach them how to do it correctly. Because if the medication just hits the back of their throat instead of their lungs, it can't possibly work. So let's treat this like a pre-flight checklist before they walk out the door. 1, steroids, confirm they understand they have to finish the full oral course. 2, controller, make sure they physically have the right daily inhaler in their hands. 3, technique, watch them use it one last time. And 4, appointment, confirm that the follow-up is actually scheduled, not just a vague suggestion. These are the 4 non-negotiables for a safe discharge. So the immediate danger has passed. We've managed the crisis. But the real work? That begins now. So the question I want to leave you with is this. How do we, as clinicians, take this frightening episode and turn it into a genuine turning point for our patients' long-term health and their quality of life?